Hi, this is Yamini Oseguera-Bhatnagar, and I'm here with Dr. Natasha Davies. It is Friday, October 2nd, and we are in Hillbrow, in the Hillbrow neighborhood of Johannesburg, South Africa. Dr. Natasha Davies runs a Safer Conception Clinic as part of the Wits Reproductive Health and HIV Institute, and will be telling us more about her work. Welcome.
Thanks.
Did you want to say anything about yourself or the work that you do?
So I work in a busy ARV clinic in the center of Johannesburg. We're in the most densely populated area of South Africa. So the ARV clinic itself has about 16,000 patients attending. And then through my experience of being an HIV clinician over the last 10 years in South Africa, I identified a need for people who are well on ARVs to want to get pregnant and carry on with their normal lives. So I started providing advice on an ad hoc basis and then became more interested in it. So since June of this year, I've been providing a formal safer conception clinic, which is a service and an implementation study to see whether it's going to work in a public government-free healthcare setting in South Africa. So that's the context of where I sit on a daily basis.
Dr. Davies, tell us about how patients find out about your services and connect with your care.
So we have a couple of different ways that they can find out. The most important one is through posters that we have up around the facility. So they're only in the Hillbrow facility at the moment, so we're recruiting from HIV testing and counselling services, primary healthcare services, male medical circumcision, family planning. If someone's decided they want to come off their contraception and to plan a pregnancy, they can get referred here. And then the main source of our referral is downstairs at the ARV clinic, where the doctors and nurses are aware and they offer people an opportunity. And then we also have some field workers out doing other research who are alert to it. So if they come across someone of reproductive age who's in an HIV affected couple, they'll offer them referral to the service.
Great. For one, I know people around the world are now thinking and talking about safer conception and how to provide it, the counseling around it, how to provide care around it, and kind of do what you're doing here. So tell us, even in the short 4-month period that you've been running, some of the things that you've seen, some of the successes you've had and the challenges you've faced.
So yeah, we started in June and uptake's been pretty quick. So we have 109 individuals at the service now. 34 of them are coming as couples, but 41 of them are unaccompanied females, one unaccompanied male. So one of the challenges has been trying to get the couple engaged together. And one of the biggest things around that is that many of the women are in situations where they're economically dependent on their male partner and they're too afraid to disclose. So a lot of the counselling that we are doing is around helping those women to feel confident enough to disclose, but also being aware of the issues around economic abandonment and gender-based violence, that they actually put themselves at risk sometimes if they do disclose. So there are good reasons why they're in relationships, they're wanting to have a child with someone, they're committed to that person, but they don't feel that it's safe to tell their partner about their HIV status. So that's difficult for myself and Sister Tuli, who's the nurse working with me, because we are giving advice about how to conceive, which inevitably involves risk in terms of HIV transmission. And we know that these women haven't told their partners. But at the same time, if we don't advise them about risk reduction strategies, then we're not doing anything of any service to the unknown partner. So we are trying to promote couples testing and counselling and to say to them, it's okay, you can go and test with your partner as though you're finding out for the first time, and then we can go forward from there. Some of them are quite open to that idea, they hadn't thought about it before, but because we're still early in the study, we haven't seen how many of them actually have taken up that option yet, because we're still working with a lot of them early on. So that's probably one of our biggest
talking earlier about the fact that you're seeing a lot of fertility issues and how that is affecting people seeking safer conception care.
So I think there's an issue around selection bias of who's coming to the service. People who have been struggling to get pregnant already, as soon as they see a poster or they hear about it from a friend or a healthcare provider, they feel finally there's a service available for me where someone's going to be supporting me to get pregnant. So we've had quite a lot of women come in who have already been trying for many years and have either never had a pregnancy, or they've had previous ectopic, or they've had miscarriages, so they don't have any live children at the moment. And that is difficult for me because that's not what I set up the clinic to do. I'm an HIV clinician, and I set it up to help HIV affected couples with HIV prevention between partners and vertical transmission. And I am not a gynecologist, so I don't have the expertise or the resources to help with fertility issues. But I'm also aware that these women are at risk of all sorts of things because they've not managed to bear a child. So I'm torn between allowing them to almost block up my service because they're not going to get pregnant easily, which means fewer people can access the service, versus having compassion for them and understanding the difficulty that they have nowhere else to go because there aren't fertility services available for free in South Africa.
Also, we were just talking earlier, and you were telling me about public health system here in South Africa and the government provided sort of healthcare services, and that STI testing is actually some STI testing is actually unavailable. Will you tell us about that?
So our national public sector STI guidelines are all syndromic based. So you screen the person with a set of questions to find out if they have any symptoms of STI, and if that screening is positive, you go on to do a clinical examination looking for obvious signs of STI. After that, we have no option except to treat them with syndromic management, which is 3 antibiotics, which are designed to blast the most common STIs. But we're not able to specifically identify if someone has chlamydia, gonorrhea, or trichomonas. And the other issue is that we know that the screening and clinical examination is not effective at picking up many of those STIs. So we're probably sitting with a lot of couples who have active STIs and we are not aware of it, which has huge implications for HIV prevention, but also for the issue of infertility, because we may be creating infertility by having women who have untreated STIs. So it's something that I really struggle with. We can do a blood test for syphilis and we can check for hepatitis B, but everything else is based on clinical findings and history taking, not on tests.
And given that gonorrhea and chlamydia tend to be asymptomatic, at least 50% of the time, this is really an issue.
Yeah, it is. It's a big issue for me, and in terms of the ethics of what we're doing, I find it quite difficult to know that the service we're providing is suboptimal. But unfortunately, this is an implementation project, so we're doing it in the public sector, and we're not allowed, well, I made the decision not to add in extra things because I want to see whether it's workable in what the resources that we have existing. So if I then get extra funding to provide a panel of STI screening, that's not going to be replicable in the other primary healthcare services where we want to expand the service to. So I have to balance up the public health versus the individual benefit and, sleep at night.
I guess that's one of the dilemmas all researchers probably face that are working in healthcare.
Yeah, I think the people who are working in implementation science specifically, if you're working in a strict research setting, you can push things as far as possible to make sure that you're providing your participants with absolutely the best. But when you're doing implementation science to see if something is doable in the real world, you have to be very careful not to provide too many extra things, because then your results are not going to be repeatable in the real world, where it's just a nurse at a primary healthcare clinic who's been trained to provide this service, and she has what she has available based on government funding. So we have to stay true to that so that we can confidently train people that this is what we found, doing exactly what you're going to be able to do.
Dr. Davies, tell us about the future of safer conception work in South Africa, and also as this begins to roll out everywhere else in the world, including the United States and Canada. What are some lessons learned?
Sure, it's a big question. I think for me, the thing that I'm starting to realize most is that we are not acknowledging that people are on a reproductive journey. So still family planning is focused on contraception and preventing pregnancies. And in South Africa, I think what the biggest challenge for this service is going to be is shifting people to understand that it's normal to desire children and that we should be supporting people to have a healthy pregnancy. And until that becomes a normal language in the medical sphere, the communities aren't going to start presenting to access those services. So in South Africa, 60% of pregnancies are unplanned, but not all of them are unwanted. So if we can try and shift the wanted unplanned to be planned so that people access services before they get pregnant, we'll be able to impact on HIV prevention, maternal outcomes, infant outcomes, picking up infertility issues, realizing what the demand is for assisted reproduction. There's so much that comes from starting to encourage people to plan their pregnancy. So for me, that's where I envisage this going, is trying to encourage a shift in the language in South Africa. That at the moment, pregnant women are kind of seen as a bit of a burden. You didn't plan this, and now we have to look after you. As opposed to, congratulations, you're pregnant, that's so amazing, you're looking forward to having a baby, let's do this with you in a positive way. So that's what I enjoy about this clinic, is I'm teaching people to be excited about the idea of having kids, the men and the women who come, and that I want the men and the women to do that pregnancy journey together so that we can improve outcomes. So that's my long-term vision of what this tiny project could eventually influence. In terms of the rest of the world, it's just another way to look at providing a health service, and I'm keen on that. I'm kind of tired of the illness services where we pick up in pieces. I want to start encouraging men especially to access care because they want to do something healthy and positive with their partner, and that maybe that will encourage men to engage in healthcare services more, test more, access treatment more, look after their ladies more, and vice versa. And that's what I've seen in the clinic. The few men who've come in, they're amazed at what they can learn. They're really engaged, they're very supportive of their partners, and the ones who've started treatment have really been very grateful that they've tested here. We found out they're positive, and they've now started on ART. So it's a new opportunity to engage a different population of HIV-infected people by using totally different messaging.
One thing that really stands out to me about the work that you're doing and what Safer Conception brings in general is the idea that there's some self-determination there, that women and just HIV-affected families get to have more control over the process of reproduction and just sort of their aspirations around it.
Yeah.
And that's a beautiful thing.
Yeah, I hope that when people are in my clinic room, they are being empowered. And the one pregnancy that we've had so far, because it's been early, we've only been going for 3 months, a lot of time was spent once we confirmed her pregnancy going through what she should expect at antenatal care, that she must take her partner with her and stand up for her rights, that he can be involved. It's his pregnancy too. They're a couple and they're going to be a family, and gradually starting to change the way that people can engage with their healthcare providers to say this is a good thing, this is a positive thing, take care of it instead of just seeing them as someone who needs to go through the process. So that's a big part of it for me, is empowering my clients to stand up for their reproductive
This was great. Thank you very much.
Cool.
We will hear more from you as time goes, I'm assuming,
Awesome.
and I know for a fact. Thank you.
Sure.